in ICU. So the main component which is participating in the respiration is the alveolus and the capillaries. So this structure is the alveolar capillary interface, which is between the alveolus and the capillaries. So there are two things which are happening: oxygen entering into the bloodstream from the air, and carbon dioxide which is getting exhaled from the bloodstream and through the alveolus and lungs into the environment. So the first one thing this is happening is the oxygen exchange. So the oxygen exchange is mainly dependent on the two factors. Oxygen from the alveolus is going to enter through the alveolar capillary interface into the capillaries. So the two factors are PEEP and FiO2. So as we titrate and set a specific optimal PEEP and FiO2, we can achieve a particular oxygenation, we can titrate the oxygenation of the patient by altering the PEEP and FiO2. So FiO2 is nothing but the fraction of oxygen, inspired oxygen, which we supply through the air. So FiO2, which is the oxygen available in the alveolus, it enters through the alveolar capillary interface into the bloodstream. So when we it's very directly related, because as we increase the inspired concentration of oxygen, there is more oxygen which is entering into the bloodstream also. It's very simple. And coming to PEEP, PEEP is the peak end expiratory pressure. So what is the importance of PEEP is, as we exhale and there is at the end of expiration, almost the lung volume decreases and the lung capacities, everything comes to the minimum, and the alveolus also starts to decrease in size and almost shrinks and starts to collapse. So what happens is, when we increase the end expiratory pressure, more of the volume of alveolus and more of alveolus, there is more room inside the alveolus, and the alveolus is almost maintained and splintered, and it is maintained and kept open even at the end of expiration. So the amount of oxygen which is remaining in the alveolus has more time, and it enters through the alveolar capillary interface into the capillaries. So the oxygenation of the patient improves drastically when we apply PEEP, because we are not allowing the alveolus to collapse at the end of the expiration. So this is the importance of PEEP. PEEP is very useful, especially in ARDS patients where the alveolar capillary interface is very thick and it's blocked, and there is no easy permeability of oxygen or any gas to exchange through the membrane. At this scenario, if we apply PEEP, an optimal PEEP for that particular patient and for that particular hemodynamics and for that particular target SpO2, when we apply PEEP, the amount of oxygen in the alveolus has more time to get absorbed into the capillaries. So there is more chance that oxygenation may improve. But there are disadvantages of applying PEEP, in the sense that when we apply PEEP more than the optimal PEEP, disease condition compresses on the capillaries. So the main thing is there is increased pressure in the capillaries. So this is backward reflected into the heart, and there is increase in the straining of the right ventricle and the right heart, and there is total disturbance in the hemodynamics of the patient, because there will be fall in BP and these hemodynamic changes, especially because this is not a optimal PEEP. This is a more PEEP for that. So this is the importance of applying an optimal PEEP and maintaining a specific FiO2 to maintain a target SpO2 for that patient. So there is so coming to the carbon dioxide exchange, the carbon dioxide exchange, unlike carbon dioxide exchange in minute rate and tidal volume. So my minute ventilation is nothing but a product of respiratory rate or tidal volume, we can achieve a more ventilation of the carbon dioxide. What is alveolar ventilation? So there is some remaining air always in the anatomical dead space and also in the lung specific segments of the generation of the bronchus also, because it is not participating in the alveolar gaseous effective alveolar gaseous exchange. So this remaining part of the lungs which is not participating in the gaseous exchange, it is not going to be participating in the ventilation of the patient. So this is a alveolar ventilation is the difference between the mid ventilation and the dead space. So which is nothing but respiratory rate into tidal volume minus dead space.